And that's how I had it in the beginning. I'm confusing myself. Okay. So if I'm doing passive, I don't know if you guys can see this, but y'all can move if you want. So we are at 90 degrees, close to it, 88, 88 degrees. And then of course normal would be. She is 130. 130. So that's good. Selection.
So you're planning to go here?
Yeah. I feel like that's right.
Yeah, it says pelvis, but I mean, I guess.
Because you can flip it, you can have it here too with like midline with the table, but I don't know how you would do midline with the pelvis. I do pelvis with like abduction.
Yeah, I feel like I use the midline of the like trunk.
Yeah,
But
I think
maybe that's what it
I think that was a
means.
typo on my part, sorry guys.
Just like axillary lines.
Yeah, well, it'll change, so it's not always gonna be mid-axillary because the further you go up, your hip actually starts to flex.
Okay.
So you just kind of find midline here.
Okay.
With greater trunking.
So I noticed that you put your hand on the knee.
Mm-hmm.
Is that what you would normally do in every situation, or is there a time when you would need to put your hands like on the back of the thigh when you're pushing it?
To flex, so here versus here,
Yes.
either one. Either one is fine. For abduction, so you find the ASIS. Again, you can find the iliac crest first. And then if you find the iliac crest and follow it anterior, don't drag your hand along the patient because that's kind of creepy. But if you palpate the iliac crest, thank you. Palpate iliac crest, you come in like this with a flat hand, hook over top of them, and then just push down. And then from there, use the heel of your hands to find the iliac crest. Okay? Once you find the iliac crest, that's your stabilizing arm, the opposite iliac crest. Okay? Is pointing towards the opposite. Stabilizing arm is pointing to the opposite iliac ASIS. Okay? Stabilizing arm should be on the ASIS, correct? Correct me if I'm wrong. Yeah. And then you're just going to abduct the leg, and the moving arm follows the anterior middle femur. And normal should be what, 40? 40 degrees?
Would it be good for us to do it sitting or standing?
Standing.
Standing.
I just wanted these guys to see.
Like us.
So standing, it would be this way. And you want to get as proximal as you can. If you're holding here, you might get a little bit too much knee flexion, just feel a little unstable, and the patient may not feel comfortable. That's just like this.
And you stop when you notice their hips start to kind of turn a little bit?
That, or you'll notice like side bending. You get side bending at the trunk.
And there's no way to stabilize?
Especially when you have really long
How
arms.
are you getting in on adduction? Like you're just.
Same thing, so everything's the same for adduction. You can actually start with this leg abducted, and then normal's 20. Any others in the supine?
Q angle?
Q angle. Do you guys remember, have you guys heard of the Q angle? Why is it important?
ACL tears.
Okay, even more general than ACL tears.
Valgus varus.
Valgus varus, but just patellofemoral
Anteversion.
problems in general. So the larger the Q angle, women are going to tend to have a higher Q angle than men. But the larger the Q angle, the more at risk you are for patellofemoral issues. So you find the middle of the patella. So remember how you palpate the patella on the medial and lateral sides. And you kind of do a medial tilt, a lateral tilt to kind of pop up, to make the patella kind of pop up underneath your hand. That's the middle of the patella. Find the ASIS. Again, you come in with a flat edge of your hand, hook over top of the bone, and then just kind of press down to make sure you're on the top of it and nowhere else. Then once you stick your thumb out, that's the ASIS. You just stick your thumb out and go inferior, that's the ASIS there. And then mid-patella is your axis. Your stabilizing arm, I guess it really doesn't matter because you're not really moving it, but one arm will point towards the ASIS, okay? And the other arm will follow along the tibial tuberosity, which is right there, inferior to the patella. And then what's a normal read for a woman?
17 to 20.
17 to 20, anything greater than 20, they're at risk for. And then for a man,
13 to 15.
13 to 15 degrees.
What about if they're less?
What about if they're less?
Varus?
I guess you could.
They could have the retroverted hip, I would imagine, but yeah.
Did you just diagnose me with a retroverted hip?
No,
Just kidding. I'm kidding.
I don't want you to have one. Yeah, you're at 10, maybe.
Um,
9, 10.
Okay, there's also flexion and extension and supine.
Of the knee. I was gonna say what? Okay, flexion extension, so you prop up the ankle, float the ankle. We'll do extension first. So of course, you've already assessed, you find that there's some limitation. The lateral joint line is your axis point. So you can actually bend the knee a little and actually find out where it bends at the joint. Then you extend it.
Would you accept lateral and condyle of the femur as a
Mhm.
axis? Okay.
And then from here, you can lift the knee. If you're doing passive, if you're doing active, you tell them to tighten the quad. And you should get some heel rise if you're doing it passive, and you should see some heel rise if they're doing it active. And normal is about 5 degrees of hyperextension. I never did tell you your stabilizing arm. It's in line with the lateral malleolus. Okay. Deflection, same points of interest. And then passively here, of course I would never measure this because it's full, it's 140. But if they're limited, 112, she's right here. Okay. You want to notate your end range feels, your end feels, so if it's empty, firm, soft, boggy, those sorts of things.
And you can measure either of those in prone as well.
You can measure them in prone, so go ahead and put on your stomach for me. You can do these sitting down too.
Is that okay?
So you still float the ankle, everything stays the same. I need you to scoot closer to me.
It says with a towel under the thigh and start at ankle. Does that make sense?
Yep.
Okay. Sorry.
Can you do this one too? Just because this thing is so big. Slide it over a little bit more for this blocking the drum. Okay. So same landmark. With the knee flex, it's easier to find your condyles, and I'll show you that too. So flexion, like so. Just make sure this moving arm stays in line with the lateral malleolus, and then with extension. Okay, with extension, I would probably have her toes float, like this part of her heels hanging off. Like, how do you let this down? Like that, and then just have her shift down a little bit so her feet are free. Can you go a little bit more? There you go. And then tighten down, tighten your quad. Good, and keep about 7 degrees of hyperextension. Some places you'll see like 10 degrees, 5 to 10 degrees of hyperextension, that's fine too. Actually need that. Do I need to do hip now?
Hip extension, is it one of the other?
Hip extension and hip internal and external.
Oh, yeah.
All right, you can lift up here. your greater trochanter, sorry,
That's okay.
or off the side of the iliac crest. You can also internally and externally rotate, and you'll find the greater trochanter. Okay, can't go really right. Stabilizing arm, midline with the pelvis, but it's not the pelvis like you do in abduction. And then from here, you want the leg extended. And I like my handhold to be above the thigh, not on the kneecap. And then you're just raising up, making sure that your moving arm follows the midline of the thigh. Okay? Everybody see that? So it's here, just like that. And what you're looking for here, pressure just happened to come up, but you don't wanna see a hyperextension at the low back, because at that point, the motion's coming from the low back and not the hip. So if you had a free hand, if you had somebody actually measuring, you would stabilize at the sacrum and do it. But since you don't and you're trying to hold the goni, you really have to be watching what's happening there, because you don't want her low back to start to feed into the motion and give you a false reading. I wanna practice those. Oh, internal, external, thank you. So internal, external rotation is real easy. It can be done in sitting or prone. So here, okay, so it's perpendicular with earth, perpendicular with the floor, and then internal rotation. So make sure your stabilizing arm stays perpendicular with the ceiling. Your moving arm stays midline with the tibial shaft. And then your axis is the tibial tuberosity, correct?
Can I go down to the ground as well?
Yes. You can go that way as well.
Anterior aspect of the mid-patella. Axis.
Okay, so why would we say that's for any branch? And I think that's about 40 degrees. And then, sorry. It's just the weird. Watch and make sure it doesn't come from that shape. You see how that's now translating in her trunk? So she's at 35 there. It should be 45. A little limited in your external. Okay. All right, practice those. It looks the same in sitting. I can show you real quick for him to do. So the same landmarks. So internal. Okay. Practice those.